of body alignment with the patient sitting, standing, or lying down. This assessment has the following objectives. Determine normal physiological changes in body alignment resulting from growth and development. Identify deviations in body alignment caused by incorrect posture. Provide opportunities for patients to observe their posture. Identify learning needs of patients for maintaining correct body alignment. Identify trauma, muscle damage, or nerve dysfunction. Obtain information concerning other factors that contribute to incorrect alignment, such as fatigue, malnutrition, and psychological problems. The first step in assessing body alignment is to put patients at ease so they do not assume unnatural or rigid positions. When assessing the body alignment of an immobilized or unconscious patient, remove pillows and position supports from the bed and place the patient in the supine position. Characteristics of a correct body alignment for the standing patient include the following. The head is erect in midline. From a posterior position, the shoulders and hips are straight and parallel. The vertebral column is straight. When observed laterally, the head is erect and the spinal curves are aligned in a reversed S pattern. The cervical vertebrae are anteriorly convex, the thoracic vertebrae are posteriorly convex, and the lumbar vertebrae are anteriorly convex. When observed laterally, the abdomen is comfortably tucked in and the knees and ankles are slightly flexed. The person appears comfortable and does not seem conscious of their position. The arms hang comfortably at the side, and the feet are slightly apart to achieve a base of support, and the toes are pointed forward. When viewing the patient from behind, the center of gravity is at midline, and the line of gravity extends from the middle of the forehead to a midpoint between the feet. Laterally, the line of gravity runs vertically from the middle of the skull to the posterior third of the foot. Characteristics of correctly body alignment for the sitting patient include the following. The head is erect, and the neck and vertebral column are in straight alignment. Body weight is distributed evenly on the buttocks and thighs. The thighs are parallel and in a horizontal plane. Both feet are supported on the floor, and the ankles are flexed for comfort. With patients of short stature, use a footstool to ensure that ankles are flexed comfortably. A 1 to 2 inch space is maintained between the edge of the seat and the popliteal space on the posterior surface of the knee. This space ensures that no pressure is present on the popliteal artery or nerve to decrease circulation or impair nerve function. The patient's forearms are supported on the armrest in the lap or on a table in front of the chair. It is particularly important to assess alignment when sitting if the patient has muscle weakness, paralysis, or nerve damage. Patients who have these problems have diminished sensation in the affected area and are unable to perceive pressure or declined circulation. Proper alignment while sitting reduces the risk of musculoskeletal system damage in such a patient. The patient with severe respiratory distress sometimes assumes the position of leaning on the table in front of the chair in an attempt to breathe more easily. This position is called orthopnea. People who are conscious have voluntary muscle control and normal perception of pressure. As a result, they usually assume a position of comfort when lying down. Because their range of motion, sensation, and circulation are within normal, they change positions when they perceive muscle strain and decreased circulation. Assess body alignment for a patient who is immobilized or bedridden, with the patient in a lateral position. Remove all positioning support from the bed except for the pillow under their head, and support the body with an adequate mattress. This position allows for full view of the spine and back and it helps provide other baseline data as whether the patient is able to remain positioned without aid. The vertebrae are aligned, and the position should not cause discomfort. Patients with impaired mobility, such as traction or arthritis, decreased sensation, as if somebody has had a stroke, and impaired circulation and lack of voluntary muscle control are at risk for damage when lying down. When assessing metabolic functioning, use anthropometric measurements such as height, weight, and skin fold thickness to evaluate muscle atrophy. Analyze intake and output records for fluid balance. Dehydration and edema increase the rate of skin breakdown in a patient who is immobilized. Monitoring laboratory data such as levels of electrolytes, serum protein levels, and BUN aid the nurse in determining metabolic functioning. Monitoring fluid intake and elimination patterns and assessing wound healing helps to determine altered GI functioning and potential metabolic problems. Perform a respiratory assessment at least every 2 hours for patients with restricted activity. The respiratory assessment includes inspecting the chest wall for movement and auscultating the lungs for decreased breath sounds, crackles, and wheezes. Cardiovascular nursing assessment of the patient who is immobilized includes blood pressure monitoring, evaluation of apical and peripheral pulses, and observation for signs of venous stasis. To assess for a DVT, or deep vein thrombosis, remove the patient's elastic stockings and SCDs every 8 hours and observe the calves for redness, warmth, and tenderness. Measure bilateral calf circumference and record it daily as an alternative assessment for DVT. Because DVTs also occur in the thigh, take thigh measurements daily if the patient is prone to thrombosis or thrombi. A dislodged venous thrombosis or thrombi, called an embolus, can travel through the circulatory system to the lungs and impair circulation and oxygenation, resulting in tachycardia and shortness of breath. Venous emboli that travel to the lungs are sometimes life-threatening. More than 90% of all pulmonary emboli begin in the deep veins of the lower extremities. Major musculoskeletal abnormalities to identify during nursing assessment include decreased muscle tone and strength, loss of muscle mass, and contractures. Early assessment of range of motion is important because it establishes a baseline against which latter measurements can be compared to evaluate whether a loss in joint mobility has occurred. Continually assess the patient's skin for breakdown and or color changes such as pallor or redness. Consistently use a standardized tool such as the Braden scale. Frequent skin assessment, which can be as often as every hour, are based on patient's mobility, hydration, and physiological status, is essential to promptly identify changes in patient's skin and underlying tissues. Evaluate the patient's elimination status on each shift and total intake and output every 24 hours. Inadequate intake and output, or fluid and electrolyte imbalances, increase the risk for renal impairment, ranging from recurrent infections to kidney failure. Dehydration also increases the risk for skin breakdown, thrombus formation, respiratory infections, and constipation. Assessment of bowel elimination status includes the adequacy of dietary choices, bowel sounds, and the frequency and consistency of bowel movements. During the psychosocial assessment, you will focus on the patient's emotional state, behavior, and sleep-wake cycle. The developmental assessment looks at how immobility affects the normal development of patients across the lifespan. Design nursing interventions that maintain normal development, provide physical and psychosocial stimuli after identifying a child's developmental needs, and assure the parents that developmental delays are usually temporary. Immobilization of a family member changes family functioning. Immobility has a significant effect on the older adult's level of health, independence, and functional status. Assessment also includes the patient's home and community to identify factors that are risk to his or her mobility and safety. The two diagnoses most directly related to mobility are impaired physical mobility and risk for disuse syndrome. The diagnosis of impaired physical mobility applies to the patient who has some limitation but is not completely immobile. The diagnosis of risk for disuse syndrome applies to the patient who is immobile and at risk for multi-system problems because of inactivity. Assessment reveals clusters of data that indicate whether a patient is at risk or if an actual problem exists. The clusters of data include defining characteristics that support the diagnostic label and probable cause of the diagnosis. Locating the probable cause of the diagnosis is important to planning patient-centered goals and subsequent nursing interventions that will best help the patient. It is critical that nursing assessment activities identify and cluster defining characteristics that ultimately support the nursing diagnosis selected. During immobilization, some patients experience decreased social interaction and stimuli. These patients frequently use the nurse's call bell to request minor physical attention when their real need is greater socialization. Nursing diagnoses for health needs in developmental areas reflect changes from the patient's normal activities. Immobility also leads to multiple complications. If these conditions develop, collaborate with a healthcare provider or nurse practitioner for prescribed therapy to intervene. Develop goals and expected outcomes to assist the patient in achieving his or her highest level of mobility and reducing the hazards of immobility. Set priorities when planning care to ensure that intermediate needs are met first. This is particularly important when patients have multiple diagnoses. Plan therapies according to the severity of the risk to the patient. Individualize the plan according to the patient's developmental stage, level of health, and lifestyle. Do not overlook potential complications. Care of the patient experiencing alterations in mobility requires a team approach. Nurses often delegate some interventions to nursing assistive personnel. Collaborate with other healthcare team members, such as physical or occupational therapists, when it is essential to consider mobility needs. In anticipation of the patient's discharge from an institution, make referrals or consult a case manager or discharge planner to ensure that the patient's needs are met at home. Health promotion activities include a variety of interventions such as education, prevention, and early detection. The rate of work-related injury in healthcare settings is on the rise. Most of these injuries occur as a result of overexertion, which results in back injuries and other musculoskeletal problems. Back injuries are often the direct result of improper lifting and bending. Get help if necessary before starting a lifting task and follow correct lifting procedures. The most common back injury is strain on the lumbar muscle group, which includes the muscles around the lumbar vertebrae. Nurses and other healthcare staff are especially at risk for injury to lumbar muscles when lifting, transferring, or positioning immobilized patients. Therefore, be aware of agency policies and protocols that protect staff and patients from injury. Current evidence supports that using mechanical or other ergonomic assistant devices is the safest way to reposition and lift patients who are unable to do these activities themselves. Exercise programs enhance feelings of well-being and improve endurance, strength, and health. Exercise reduces the risk of many health problems such as cardiovascular disease, diabetes, and osteoporosis. Exercise has many positive health benefits. Assist patients in overcoming barriers to physical activity and encourage them to perform activities that are within their ability. Take cultural practices into consideration. For patients diagnosed with osteoporosis, early evaluation, consultation, and a team approach are important interventions, especially when they become immobilized. ADLs help a patient maintain independence. Assistive ambulatory devices, adaptive clothing, and safety bar help to maintain independence. Patient teaching needs to be focused on limiting the severity of the disease through diet and activity. Because the body needs protein to repair injured tissue and rebuild depleted protein stores, give the immobilized patient a high-protein, high-calorie diet. A high-calorie intake provides sufficient fuel to meet metabolic needs and replace subcutaneous tissue. Also ensure that the patient is taking vitamin B and C supplements when necessary. Supplementation with vitamin C is needed for skin integrity and wound healing. Vitamin B complex assists in energy metabolism. If the patient is unable to eat, nutrition must be provided parentally or enterally. For respiratory patients, they need to frequently fully expand their lungs to maintain their elastic recoil property. In addition, secretions accumulate in the dependent areas of the lungs. Often patients with restricted mobility experience weakness, and as this progresses, the cough reflex gradually becomes inefficient. All of these factors put the patient at risk for developing pneumonia. The stasis of secretions in the lungs is life-threatening for an immobilized patient. A variety of nursing interventions are available to expand the lungs, dislodge and mobilize stagnant secretions, and clear the lungs. All of these interventions help reduce the risks of pneumonia. Prevention begins with assessment. Assess the patient's respiratory status per agency policy. Assessment findings that indicate pneumonia include productive cough with greenish yellow sputum, fever, pain on breathing, and adventitious lung sounds such as crackles and wheezes, and difficulty breathing. It is essential to implement pulmonary interventions in all patients, even those who do not have pneumonia. Encourage the patient to deep breathe and cough every 1 to 2 hours. Teach alert patients to deep breathe and yawn every hour or so and to use their incentive spirometer. Instruct the patient to take in 3 deep breaths and cough with a 3rd exhalation. Chest physiotherapy, which is also called percussion and positioning, is another effective method for preventing pneumonia and keeping the airway clear. CPT helps the patient drain secretions from specific segments of the bronchi and lungs into the trachea, so he or she is able to cough and expel them. Ensure the patients who are immobile take an adequate fluid intake. Unless there is a medical contraindication, an adult needs to drink at least 1,400 ml of non-caffeinated fluids daily. This helps keep the mucociliary clearance normal. When patients who are on bed rest are able to move or standing position, they often experience orthostatic hypotension. They have an increased pulse rate, a decreased pulse pressure, and a drop in blood pressure. If symptoms become severe enough, the patient can faint. Mobilize the patient as soon as the physical condition allows, even if this only involves dangling at the bedside or moving to a chair. The nurse designs interventions to reduce cardiac workload, which is increased by immobility. A primary intervention is to discourage the patient from using the Valsalva maneuver. This increases intrathoracic pressure, which in turn decreases venous return and cardiac output. When the strain is released, venous return and cardiac output immediately increase, and the systolic blood pressure and pulse pressure rise. Teach the patient to breathe out while moving side to side or up in bed. The most cost-effective way to address deep vein thrombosis is through an aggressive program of prophylaxis or prevention. It begins with identification of patients at risk and continues through their immobilization. Leg, foot, and ankle exercises, regularly providing fluids, position changes, and patient teaching need to begin when the patient becomes immobile. Common dosage for heparin therapy for DVT prophylaxis is 5,000 units given subcutaneously 2 hours before surgery and repeated every 8 to 12 hours until the patient is fully mobile or discharged. Common dosages of Lovenox, which is a lower molecular weight heparin, in the prophylaxis of DVTs is 30 to 40 milligrams subcutaneously 2 hours before surgery and continued every 8 to 12 hours throughout the post-op period. Because bleeding is a potential side effect of these medications, continually assess the patient for signs of bleeding such as hematuria, bruising, coffee ground like vomitus or GI aspirate, guaiac-positive stools, and bleeding gums. SCDs and intermittent pneumatic compression boots are used to prevent blood clots in the lower extremities. Elastic stockings, sometimes called anti-embolotic stockings, also maintain external pressure on the muscles of the lower extremities and thus promote venous return. Proper positioning reduces the patient's risks of thrombus formation because compression of the leg vein is minimized. Range of motion exercises reduce the risk of contractures and aid in preventing thrombi. Exercises to prevent excessive muscle atrophy and joint contractures help maintain musculoskeletal function. If the patient is unable to move part or all of the body, perform passive range of motion exercises for all immobilized joints while bathing the patient and at least 2 or 3 more times a day. If one extremity is paralyzed, teach the patient to put each joint independently through its range of motion. Patients on bed rest need to have active range of motion exercises incorporated into their daily schedules. Teach patients to integrate exercises during their ADLs. Some orthopedic conditions require more frequent passive range of motion exercises to restore the function of the injured joint after surgery. Patients with such conditions need to use automatic equipment such as a continuous passive motion or a CPM machine. The major risk to the skin from restricted mobility is the formation of pressure ulcers. Repositioning every 2 hours and providing skin care will help to prevent pressure ulcers. Interventions aimed at prevention include positioning, skin care, and the use of therapeutic devices to relieve pressure. Change the immobilized patient's position according to his or her activity level, perceptual ability, treatment protocols, and daily routines. Although turning every 1 to 2 hours is recommended for preventing ulcers, it is sometimes necessary to use devices for relieving pressure. Usually the time that a patient sits uninterrupted in a chair is limited to 1 hour. Reposition patients frequently because uninterrupted pressure can cause skin breakdown. Teach patients to shift their weight every 15 minutes. Chair-bound patients need to have a device for the chair that reduces pressure. The nursing interventions for maintaining optimal urinary functioning are directed at keeping the patient well hydrated and preventing urinary stasis, calculi, and infections without causing bladder distension. Adequate hydration, like we said, at least 1,400 ml of non-caffeinated fluids daily, help prevent renal calculi and urinary tract infections. Record the frequency and consistency of bowel movements and provide a diet rich in fluids, fruits, vegetables, and fibers to facilitate normal peristalsis. People who have a tendency towards depression or mood swings are at greatest risk for developing psychosocial effects during immobilization. Anticipate changes in the patient's psychosocial status and provide routine and informal socialization. Observe the patient's ability to cope with mobility. Nurses provide stimuli to maintain a patient's orientation. Planning nursing activities so the patient is able to talk and interact with staff. Involve patients in their care whenever possible. Ideally, immobilized patients continue normal development. Nursing care needs to provide mental and physical stimulation, particularly for a young child. Older patients who are frail or have chronic illnesses are often at increased risk for the psychosocial hazards of immobility. Maintaining a calendar and a clock with a large dial, conversing about current events and family members, and encouraging visits from significant others reduce the risks of social isolation. Nurses need to encourage older immobilized patients to perform as many ADLs as independently as possible. Patients with impaired nervous, skeletal, or muscular system functioning and increased weakness often require help from the nurse to attain proper body alignment while sitting in bed. Several positioning devices are available for maintaining good body alignment for patients, including pillows, positioning boots, ankle-foot orthoses, blankets, sandbags, hand rolls, and splints. A trochanter roll prevents external rotation of the hips when the patient is in a supine position. To form a trochanter roll, fold a cotton blanket lengthwise to a width that extends from the greater trochanter of the femur to the lower border of the popliteal space. Place the blanket under the buttocks and roll it counterclockwise until the thigh is in neutral position or inward rotation. When the hip is aligned correctly, the patella faces directly upward. Hand rolls maintain the thumb in slight adduction and in opposition to the fingers, which maintain a functional position. The trapeze bar is a triangular device that hangs down from a securely fastened overhead bar that is attached to the bed frame. It allows the patient to pull with the upper extremities to raise the trunk off the bed, assist in transfer from bed to wheelchair, or perform upper arm exercises. It increases independence, maintains upper body strength, and decreases the shearing action from sliding across or up and down the bed. Following guidelines reduces the risk of injury to the musculoskeletal system when the patient is sitting or lying. When joints are unsupported, their alignment is impaired. Likewise, if joints are not positioned in a slightly flexed position, their mobility is decreased. During positioning, also assess for pressure points. In the supported Fowler's position, the head of the bed is elevated 45 to 60 degrees, and the patient's knees are slightly elevated without pressure to restrict circulation in the lower legs. The following are common trouble areas for the patient in the supported Fowler's position. It can cause increased cervical flexion because the pillow at the head is too thick and the head thrusts forward. Extension of the knee, allowing the patient to slide to the foot of the bed. Pressure on the posterior aspect of the knees, decreasing circulation to the feet. Unprotected pressure points at the sacrum and heels. An increased shearing force on the back and heels when the head of the bed is raised greater than 60 degrees. Patients in the supine position rest on their back. In the supine position, the relationship of body parts is essentially the same as in good standing alignment, except that the body is in the horizontal plane. The following are some common trouble areas for patients in the supine position. The pillow at the head is too thick, increasing cervical flexion. Head is flat on the mattress. The shoulders unsupported and internally rotated. The elbows extend. The hips externally rotate. And unprotected pressure points at the occipital region of the head, vertebrae, coccyx, elbows, and heels. The patient in the prone position lies face down or chest down. Often his or her head is turned to the side, but if a pillow is under the head, it needs to be thin enough to prevent cervical flexion or extension and maintain alignment of the lumbar spine. Assess for and correct any of the following potential trouble points with the patient in the prone position: neck hyperextension, hyperextension of the lumbar spine, and plantar flexion of the ankles. In the side lying or lateral position, the patient rests on the side with a major portion of body weight on the dependent hip and shoulder. A 30-degree lateral position is recommended for patients at risk for pressure ulcers. The following trouble points are common in the side lying position: lateral flexion of the neck, spinal curves out of alignment, shoulder and hip joints internally rotated, adducted or unsupported, lack of foot support, lack of protection for pressure points at the ear, shoulder, anterior iliac spine, trochanter, and ankles, excessive lateral flexion of the spine if the patient has large hips and a pillow is not placed superior to the hip at the waist. The Sims position differs from the side lying position in the distribution of the patient's weight. In Sims position, the patient places the weight on the anterior ilium, humerus, and clavicle. Trouble points common in Sims position include the following: lateral flexion of the neck, internal rotation, adduction, or lack of support to the shoulders and hips, lack of foot support, lack of protection for pressure points at the ilium, humerus, clavicle, knees, and ankles. Always ask the patient to help to the fullest extent possible. To determine when the patient is able to do alone and how many people are needed to help move him or her in bed. Assess him or her to determine whether the illness contradicts exertion, for example, cardiovascular disease. Next, determine whether the patient comprehends what is expected. Then determine his or her comfort level. It is important to evaluate your personal strength and knowledge of the procedure. Finally, determine whether the patient is too heavy or immobile for you to move alone. The goal of restorative care for the patient who is immobile is to maximize functional mobility and independence and reduce residual functional deficits such as impaired gait and decreased endurance. The focus in restorative care is not only on ADLs that relate to physical self-care, but also on instrumental activities of daily living. IADLs or activities are necessary to be independent in society beyond eating, grooming, transferring, and toileting. They include such skills as shopping, preparing meals, banking, and taking medications. Work collaboratively with patients and other healthcare professionals. To ensure adequate joint mobility, teach the patient about range of motion exercises. When performing passive range of motion exercises, stand at the side of the bed closest to the joint being exercised. Perform passive range of motion exercises using a head-to-toe sequence and moving from larger to smaller joints. If an extremity is to be moved or lifted, place a cupped hand under the joint to support it. Support the joint by holding the adjacent distal and proximal areas, or support the joint with one hand and cradle the distal portion of the extremity with the remaining arm. When a patient has a limited ability to walk, assess his or her activity tolerance to upright position, strength, presence of pain, coordination, and balance to determine the amount of assistance needed. Explain how far the patient should try and walk, who is going to help, when the walk will take place, and why walking is important. In addition, determine with the patient how much independence he or she can assume. Check the environment to be sure that there are no obstacles in the patient's path. Provide support at the waist by using a gait belt so the patient's center of gravity remains midline. Patients with hemiplegia, one-sided paralysis, or hemiparesis, one-sided weakness, often need assistance with walking. In the event that a patient falls you should do a controlled fall, which means you would want to stand with your feet apart to provide a broad base of support. You would extend one leg and let the patient slide against it to the floor, and then you would bend your knees to the lower body as the patient slides to the floor. In the evaluation stage, you might ask, were the goals met or is more work required? You must now determine with the patient and how others involved with care if the goals or outcomes established with and for the patient have indeed been met. What still needs to be achieved from the patient's perspective and the construction of a new plan of care if needed. In other words, how have the patient's expectations changed and in what ways? From your perspective as a nurse, you are to evaluate outcomes in response to nursing care and compare the patient's actual outcomes with the outcomes selected during planning, such as his or her ability to maintain or improve body alignment, joint mobility, walking, moving, or transferring. When outcomes are not met, consider asking the question, are there any ways we can assist you to increase your activity? Which activities are you having trouble completing right now? How do you feel about not being able to dress yourself and make your meals? Which exercise do you find most helpful? And what goals for your activity would you like to set now? Ensuring patient safety is an essential role of the professional nurse. To ensure safety, communicate clearly with members of the healthcare team, incorporate the patient's priorities of care and preferences, and use best evidence when making decisions about your patient's care. When performing the skills in this chapter, remember the following points to ensure safe, individualized, patient-centered care. Determine the amount and type of assistance required for safe positioning, including any transfer equipment and the number of personnel to safely transfer and prevent harm to patients and healthcare providers. Raise the side rail on the side of the bed opposite of where you are standing to prevent the patient from falling out of bed. Arrange equipment such as feeding tubes, catheter lines, and intravenous lines so they don't interfere with the positioning process. And evaluate the patient for correct body alignment and pressure risks after repositioning.